Good morning. We are going to have the usual episode of the webinar by East West Pharma. It is an initiative by East West Pharma. It is for the educational purpose of all pan-India dermatology postgraduates. So every episode we are getting eminent speakers, and this time we are very fortunate to have a personality like Dr. Angan Gupta. You might not have heard about Dr. Angan Gupta, but I have a very long acquaintance with Angan Gupta, and he's a very brilliant dermatologist, I should say. Very brilliant, right from the education, from the postgraduate studies. Now he is occupying a very prestigious position in Blacktown, Australia, as a senior registrar. Now, Angan Gupta is a versatile dermatologist. He is not one who is confined to one area of dermatology. He is very well versed in clinical dermatology, dermatopathology, pediatric dermatology, and of course, the procedures. So right now, I have selected this particular topic for Angan Gupta himself because we want to know more about neutrophilic dermatosis. Neutrophilic dermatosis is a very challenging field. You may come across a lot of neutrophilic dermatosis in your day-to-day practice. But the problem is we are not bothered about the correct diagnosis. And we treat with, shortcuts. But that is not good for the patient as such. And of course, for our improvement, educational or quality output from you. So Dr. Angan Gupta will be telling you more specifically about the neutrophilic dermatosis. And I think we will be fortunate to have Dr. Angan Gupta today. And over to you, Angan Gupta.
Good morning, everyone. Thank you, sir. Thank you for your words. The honor and privilege is all mine. I remember you were one of the judges in one of the first quizzes I won as a postgraduate in TAISA in Ahmedabad. And from you, having those words, it means a lot. I'll try to do justice and I'll share my screen. I've prepared this talk keeping postgraduates in mind. So it's a very basic talk, and I will touch upon things which are not so basic and which I want them to go back and go through them through the textbook. And I have in the end given a couple of suggested reading articles which are free to access. Any questions? I'm happy to answer them during the talk or after the talk, however you feel like. I have divided my talk into three parts. The first part would be discussing the definitions, the problems in the definitions, how difficult it is for someone to call something a neutrophilic dermatosis because of the various definitions and various classification criteria that we have. After that, I'm going to talk about a diagnostic workup on how to come to the diagnosis and what all is required once you have called something a neutrophilic dermatosis. And in the end, I'm going to discuss the management options and how to choose the best management for a particular person. I have not covered Behçet's and EED in this talk because I think they're best covered when we talk about vasculitis and autoinflammatory dermatosis, which are now equated to neutrophilic dermatosis. I have not touched upon them as well, only because it becomes too complicated, and I'd like to have a good 20-minute, 25-minute concentration from you all so that we can cover the topics which are important for your exams, and mostly 99% of the patients that you will see which are neutrophilic dermatosis, I'm going to cover them first. Okay, so the definition which is the most accurate, which I find is any skin lesion which has a predominantly neutrophilic infiltrate on histopathology is a neutrophilic dermatosis, provided you've ruled out infection using tissue cultures and you've ruled out a true vasculitis. However, you can have some kind of vasculitis, and I'm going to describe that once we discuss histopathology. So any neutrophilic infiltrate in the skin biopsy, which has no other predominant feature, I'm going to call it neutrophilic dermatosis. When it is present in the epidermis, it generally presents as a pustule. When it is present in the dermis, you see boggy plaques. These are infiltrated plaques. And sometimes you can have panniculitis also because of neutrophilic dermatosis. And the two more common reasons, or the two important reasons you must not forget, are the pancreatic panniculitis and the alpha trypsin 1 antideficiency panniculitis. Most important thing here would be always rule out infection, and you've got to do tissue cultures for bacteria, for fungi, and for mycobacteria, which can present in identical way as neutrophilic dermatosis. Now we have all these definitions and we don't respect the disease much, and we say we have to diagnose once we have ruled out all other conditions. And I've had postgraduates who come to me and they say, so this is a case of pyoderma gangrenosum. And you ask them, how do you feel? Because of the evolution of the lesion and the fact that they are painful and they fulfill the criteria. I must tell you, I have been fooled as a junior dermatologist before. You have to rule out cultures, and I have burnt my fingers myself, and I don't really, I don't find shame in accepting that I have treated a deep fungal infection as pyoderma gangrenosum just because the tissue cultures didn't grow at that time and we lost the patient. So you must rule out the infections before you diagnose a neutrophilic dermatosis. And the other wrong concept which you all develop is that you feel that neutrophilic dermatosis will be associated with neutrophilia in the blood. You will have a high neutrophil count, which is not always correct. If you have a neutrophilic dermatosis in a setting of a hematological malignancy, which is one of the common situations where you have neutrophilic dermatosis, you'll have a total count of about 400. So you can have neutropenia also, and you can have a neutrophilic dermatosis with normal counts also. So it is not must that you have neutrophilia in blood also. The neutrophilic infiltrate has to be present in the skin biopsy as the predominant feature. Now, it is very difficult to classify neutrophilic dermatosis, and I'm going to elaborate that because it has variable presentations. It can present as a macule, it can present as a wheal, it can present as a pustule, like I just said, it can present as infiltrated plaques or nodules, or directly as ulcers. So it can have variable presentations, and then it can have involvement of any of the organ systems. The most common organ system, I think, is the musculoskeletal system, where you have arthralgia and arthritis. The second most common, according to literature as well as our experience, is the eye, where you got conjunctivitis, iritis, and various other things. Splenic abscess, I've had one relative who I diagnosed as neutrophilic dermatosis who only had a splenic abscess and nothing else. And then subsequently, the patient developed skin lesions, and then we put two and two together. So you can have isolated systemic involvement as well. The crux again is you have an abscess, you have a neutrophilic dermatosis, and you do not find any infection in it. That makes it neutrophilic dermatosis, and you have to act accordingly. Now, the classifications are various. If you look at your textbooks, you'll have three classifications. One is which is based on the classification criteria. Now, Sweet syndrome and pyoderma gangrenosum, they have their own criteria, whereas the other neutrophilic dermatosis, most of them do not have their own classification criteria. The second classification, which I have chosen for today's talk, is based on the localization of neutrophils. Where are the neutrophils located? And the third is based on the location of the rash on the skin clinically. So if you have it on the hands, lesion is on the hand, you can call it neutrophilic dermatosis of the hands, provided it doesn't fulfill the classification criteria of the known neutrophilic dermatosis. And similarly, we've got another one, which is facial neutrophilic dermatosis. And then the list is endless. The more articles you'll read, you'll see there are very learned authors who have tried to declassify and then reclassify neutrophilic dermatosis into various other forms. So for today, what we're going to use is from your textbook. This is neutrophilic dermatosis, which involves only the epidermis, which means a sterile pustule. If you have a pustule and you've ruled out candida, you've ruled out impetigo, you've ruled out a malassezia. So it's a non-infectious pustule. You'll have pustular diseases of the epidermis. These are neutrophilic dermatosis of the epidermis. Neutrophilic dermatosis of the dermis are the infiltrated plaques where sweet syndrome and pyoderma gangrenosum are the ones which are the prototype and which we're going to discuss in detail. And the one which is most common in my practice is the neutrophilic urticaria. However, now there are good number of articles to prove that the known entities like Sappho syndrome, hidradenitis suppurativa, follicular occlusion triads and tetrads, they are all basically neutrophilic dermatosis because if you look at their biopsies, they are all neutrophil rich with no other particular finding. However, in hidradenitis suppurativa, I accept you can have a granulomatous inflammation as well. So if you look at these entities, keratoderma belenoragicum, a manifestation of reactive arthritis, not generally thought out to be a neutrophilic dermatosis, but I mean, if you look deeply, it is a neutrophilic dermatosis. Same goes for Still's disease and the others which are in this uh, uh, table. Another neutrophilic dermatosis, which is way more common than the ones which are mentioned and which has no mention in the classification, is scalp pustulosis. You take a biopsy and it's just a neutrophilic inflammation of the interfollicular area of the epidermis, and it has no mention in neutrophilic dermatosis. So there are entities which are still present, which show neutrophilic infiltration, and they do not find mention in the classification as of yet. So I think it's a process in making, and over a period of time, maybe subsequently we'll get a classification which is more comprehensive. Now we'll start with the first one, which is the sweet syndrome. This is the prototype of neutrophilic dermatosis, also known as acute febrile neutrophilic dermatosis. Eponymously used name, sweet is the name of the dermatologist who described this condition. And you need four primary features here. You need to have an acute uh, eruption of tender erythematous to violaceous papules and plaques. But you can have other clinical variants. I'm going to show you photographs. And one classical thing you see is on top of these plaques, you will see that pseudovesicular surface which has an irregular border. Like I said, the biopsy should show neutrophilic infiltration and it should not have a true vasculitis. It should not show necrosis of the endothelial cell wall. Sweet syndrome, generally the patient has fever and they also have constitution symptoms. So it's a sick patient. And in sweet syndrome, you generally end up having peripheral neutrophilia also. So these are the four primary features, and there is a criteria also, the major and the minor criteria. This is one of the criteria of sweet syndrome, and there are other criteria as well. But basically, you have a sick patient who has fever with infiltrated plaques and nodules, and on biopsy, you do not see any evidence of any infection. This is a neutrophilic dermatosis, and this is sweet syndrome. These are some of the photographs. If you look at the first one, where you have these infiltrated plaques on the scalp with the pseudovesicular appearance, and you can make out the red eye here also. This one's a little more prominent. We were initially treated as cellulitis, obviously for the infiltrated tender red plaque on the extremity with pustulation on top. You can have a targetoid-like appearance of sweet syndrome where you have target-like appearance here, and you can have a pustulo-bullous eruption also. So again, when you see someone like this and a patient is sick, even though your first thought process is that it's sweet syndrome, but this could very well be an erythema nodosum leprosum or any of the bacterial or the mycobacterial infections also. So you must take tissue cultures, be sure that you're not dealing with an infection, and then treat them as sweet syndrome. Like I said, you have systemic involvement in sweets, and this is a patient who had dactylitis, a very painful index finger, and the tenosynovitis of the wrist. This definitely, even though the skin lesions were not so prominent, the systemic features were more prominent in this patient. So this is the biopsy. You have this light area, which is the dermal edema, the boggy swelling that I said. You have dermal edema, which is the light colored area. And you have a diffuse interstitial neutrophilic infiltration here. And then you see some perivascular inflammation also. If you go into the biopsy, you will see there is some form of leukocytoclasia and karyorexis, but you would not find a true vasculitis because you must understand where are these neutrophils coming from in the interstitium? They are all coming out from the blood vessels. So when they're coming out from the blood vessels and you take a biopsy, you may see neutrophils around the blood vessels as well. So you have some vasculitis, but it's not a true vasculitis. There are two histopathological variants which I want you to understand. Again, a diffuse neutrophilic infiltrate. If you go in, you see this round basophilic bodies with a capsule around it. You do a IHC on it, they'll be positive for myeloperoxidase and they'll be negative for fungal elements. So this is cryptococcoid sweets, clinically presents as classical sweets. However, the biopsy is cryptococcus like the fungal infection, and it's cryptococcoid sweets. The other one, which is more popular, is the histiocytoid sweets, a part of a lot of quizzes in post-graduation. And sometimes if you're doing good in your vivas in the exam, they generally tend up asking these rare entities, and histiocytoid sweets is another one where you see immature neutrophils which do look like histiocytes with no cytoplasm around it, but IHC with a clinical suspicion for MPO and early neutrophil markers are positive, and it's negative for the histiocytic markers. So it's a histiocytoid sweets. One important thing for histiocytoid sweets is histiocytoid sweets is it's very commonly associated with myelogenous leukemias. So this is a patient who you will have to come, get across a hematologist and get their opinion on what they feel about it and get the workup done to rule out a hematological malignancies in these patients. The second entity I'm going to talk about is pyoderma gangrenosum, or PG as we call it. So this is a painful ulcerative neutrophilic disease where you may or may not have systemic features, generally affects the extremities, whereas sweet syndrome generally affects the head and neck area. This affects the extremities. Now, there are situations where you have a sweet syndrome patient with vesiculation who develop superficial ulcerations, and we're not really sure whether to put it as a pyoderma gangrenosum or whether to put it as a sweet syndrome. It's not very important because the associations remain the same and management also remains more or less the same. But the classical pyoderma gangrenosum is a tiny pustule which has a rapid progression, and it develops into a nodule or a hemorrhage bulla, and then you have an ulcers which continue to progress in size at a very fast pace, and they are painful. Again, like sweet syndrome, you've got few variants. And pyoderma gangrenosum, just like sweets, they all have their classification criteria. The one which is mentioned in most of the textbooks is SU criteria, but now we have 2018 Paracelsus score, which is a little more accurate, I'd say. I have not put it here. You can go back and look at in the journals. They're all free to access articles. But these are the three scoring systems that are available. Some classical image. So this is pyoderma gangrenosum, the ulcerative variant, where you have this violaceous border edges, and we have an undermined edge here, and are very rapidly progressing. This is a patient who had a fistulating Crohn's disease. I've spent about 6 years with her. Very difficult to manage. She developed a pyoderma gangrenosum. Initially, it involved the entire peristomal area, and she had it around the perianal area as well. Took most of the traditional drugs, did not get better, started on adalimumab, did better on the pyoderma gangrenosum, but developed a florid paradoxical psoriasis because of TNF alpha inhibitors. Then we had to give TNF alpha inhibitors with high dose methotrexate, and she's doing okay now. So this is peristomal pyoderma gangrenosum. And then you have bullous pyoderma gangrenosum, where you have classical pyoderma gangrenosum and you'll have a bulla alongside it. And you can have a pustular pyoderma gangrenosum, for some reason very commonly seen on the genitalia, as well as can be seen on the trunk. Again, when you see something like this, even though you have a thought process, no, this is pyoderma gangrenosum, but you must rule out. I've had cases which looked like pustular pyoderma gangrenosum and they turned out to be tuberculid. And this definitely has many more differentials. So rule out infection, rule out vasculitis, which would mean you need to be more aggressive when you have vasculitis, and then you diagnose neutrophilic dermatosis. Necrotizing pyoderma gangrenosum or necrotizing sweets was initially a variant of one of those entities, but like I said, names are not important. You must recognize that neutrophilic dermatosis can look like a necrotizing fasciitis as well. The problem here is the patient has these ulcers, they look infected, they have fever, they are in shock. You'll see the blood count, the total counts are about 48,000 neutrophilic, and you have a leukemoid reaction. So you don't really have the guts to give them steroids or anti-inflammatory agents at that stage. The only thing you think about is, I've got to give him antibiotics. I've got to uh, uh, do an IND and open it up. But we must recognize that neutrophilic dermatosis, they show pathergy. That's something like a Kubner's phenomena, where the more trauma you give, the more extensive the wound becomes. But that's how it is. You never diagnose a necrotizing neutrophilic dermatosis when the patient walks to you in the casualty or in your OPD. The first thought has to be an infection. We end up, sometimes losing the limbs also. Because it's a game of statistics, where we've got to realize that infections are generally more common than non-infectious necrotizing neutrophilic dermatosis. So if the patient is not responding to the antibiotics and the cultures show no response, I think it's then you should have a suspicion that this is possibly a necrotizing neutrophilic dermatosis, and we've got to start steroids or cyclosporin and one of the anti-inflammatory agents. But it's a tough one. The easy one to manage, mostly self-limiting, is neutrophilic eccrine hidradenitis. It can happen anywhere on the body. Looks a lot like sweets, behaves a lot like sweets, almost self-limiting. But the two things that you must remember about this condition is, one is it's almost always seen with AML or CML, with patients who are on azacitidine or cytarabine, preferable side chemotherapies. And the biopsy shows neutrophilic infiltrate along the perieccrine region only, where you have the secretory cells which also get necrosed with the inflammation that it shows. This is way more common than most people believe. A lot of patients with the chronic spontaneous urticaria which do not respond to the traditional antihistamines and then omalizumab, and we end up giving them cyclosporin. Uh, you know, we've we've kind of over a period of years started doing biopsies in these patients, and they show neutrophilia. So even in the absence of the periodic syndromes and in the absence of SLE, I've seen a fair bit of neutrophilic urticaria. Again, you do a biopsy and you see neutrophilic infiltrate. It's not the eosinophilic infiltrate with mast cells that you expect in urticaria. So it presents exactly like urticaria, a non-responsive urticaria, and it's generally a diagnosis which is made in retrospect, and you go back and do a biopsy, and then you go back. Probably from the beginning, the patient had neutrophilic urticaria. So this is the last slide on the clinical features, and then I go to the workup. I've put all the pustular conditions together. This is an important table because this is pemphigus is something you always have in your exam. So any pustular condition, you must know the difference between these, and I encourage you to take a screenshot so that you have these readily with you. Now, of the lot, AGAP is something where you have a classical drug history, very rarely an infection induced. AGAP is also seen. Otherwise, rest of them are chronic relapsing conditions. The locations in a pustular psoriasis, it's a generalized rash, whereas in AGAP, IgA pemphigus, amicrobial pustulosis, and SCPD, generally it's an intratriginous or a flexural rash preferably, but it all can be systemic also. Histopathology is more or less the same. You have neutrophilic infiltrate. In pustular psoriasis, you'll see psoriasiform change in the epidermis, and the other normal psoriasis changes as well. In AGAP, you'll see eosinophils also alongside epidermis, also alongside neutrophils in the epidermis, because it's a drug-induced change, whereas the others are just simple intraepidermal pustules. Whenever you have a circinate pattern, there is a thought process that it could be a pemphigus foliaceus or an IgA pemphigus, and we'd end up doing a DIF in these patients. So if you have IgA deposits, it become an IgA pemphigus, and then you have IgA pemphigus like SCPD as well. I'm not going to go dwell into it, but that's something you must know. The patients with pustular psoriasis and AGAP are generally sick when they come to us. They have fever, they have constitutional symptoms. You must know the triggers and the drugs. For pustular psoriasis, it's an emergency. You end up starting retinoids or cyclosporin or systemic steroids, whereas AGAP is managed uh, uh, conservatively with just stopping the drug and giving topical steroids. At max, we sometimes give a low dose steroid for a few days. For these entities, IgA pemphigus and SCPD, we give anti-neutrophilic agent, dapsone being the drug of choice. And for amicrobial pustulosis, you must, because this is mostly associated with an autoimmune disease, you treat the autoimmune disease extensively and treat the pustules symptomatically, and that's how it is. Now, going to the workup. Of course, the first thing that you must do is do a skin biopsy and confirm your diagnosis. you must rule out your differential diagnosis. So the first differential we have for most of the sweets patient we see is erythema nodosum leprosum. So we end up doing skin smears. We would do the uh, cultures for atypical mycobacteria, for bacteria, for fungal, like I said. And the most important thing is once you have diagnosed something as a neutrophilic dermatosis, you must see whether patient has an occult disease underneath. There are high chances that patients with SCPD will have some kind of a gammopathy or a monoclonal, uh, one of those paraproteinemias. With neutrophilic eccrine hidradenitis, although it happens in a patient who has a myelogenous leukemia who's on drugs, but it can sometimes unmask a leukemia underneath. Pyoderma gangrenosum, sweet syndrome, your threshold to ask a gastroenterologist to look for an inflammatory bowel disease, do endoscopies and colonoscopy should be low. These are associated entities, and unless you treat the entity which is underneath, you are unlikely to get a good outcome for the treatment of neutrophilic dermatosis. Now, coming to the management, which is the last part of my slide. uh, we must know what is the mechanism of neutrophilic dermatosis to know. So what happens is because of the undercurrent condition or the drug or the infection, whatever starts the inflammation, you have abnormal neutrophil function, which deposits into the skin. And the two important cytokines which help in all of this is interleukin 1 and TNF alpha, with a major role of interleukin 12, 23 as well. So obviously the drugs that we would use is first anti-neutrophilic agents, and then we'll use the biologics which are targeted towards these cytokines. And for pustular psoriasis, I have not been fortunate enough to use the spesolimab till now, but we have an IL-36 inhibitor also for intraepidermal pustules. It doesn't seem to have a role in dermal or spanniculated neutrophilic dermatosis, but IL-36 inhibitor single infusion has shown good response in patients with epidermal neutrophilic dermatosis, especially the pustular psoriasis and the monogenic pustular psoriasis, DIRA, DITRA. I'm not going into those today, but you must know about them when you have a patient with pustular psoriasis, that there are monogenic conditions which are treated with IL-36 inhibitors. So how do you do? You have to first treat the underlying problem. If you have a patient with RA, SLE or IBD, you need to increase your immunosuppression. A presence of neutrophilic dermatosis means that the trigger for neutrophilic dermatosis is present and is not under control. So you've got to control the trigger first. If it's an associated malignancy, treat the malignancy first. If it is because of the drug, you stop the drug. And like I said, recognize a monogenic cause. If it's an early onset pustular psoriasis, if it's an early onset sweet syndrome like disease, you must think about autoinflammatory dermatosis and refer them to a higher center where you can have a genetic drug test done. And based on the final diagnosis, now we have several drugs which target. One of those is ruxolitinib, which is shown to have a very good response in certain autoinflammatory disorders. So that's something that you must do. Now, what do we do once we have the rash? If it's a very localized or a very mild disease, we start with potent topical corticosteroids or tacrolimus or pimecrolimus. We must not forget these generally end up forming a wound. So you must know how to do a wound care. And we are very bad at it, dermatologists, but we must manage the pain of the patient, and we should not be conservative about the pain management and use opioids if it is needed. So I've I've noticed that patients with painful pyoderma gangrenosum walking on crutches or on wheelchairs having a lot of pain, and we don't really give them opioids because we're not used to using them. But these are painful conditions, and we must take help from our colleagues and give them adequate analgesia. Now, like I said, these are the conditions where the diagnosis happens a few days later. You get to the diagnosis only when the biopsy is ready, the cultures are negative. What to do in that period when you don't know whether the patient has a neutrophilic dermatosis or not? So these are generally the drugs which we start when we have a suspicion, because these are not anti-inflammatory they don't really there's no problem in giving them even if the diagnosis is incorrect and the patient has an infection. So a potassium iodide saturated solution, which is given as drops, colchicine or dapsone, fantastic drugs. I mean, sometimes not effective, but uh, in a situation where you are not willing to give an immunosuppressive immediately, these are fantastic drugs. Anti-inflammatory, I mean, if you have to choose an antibiotic, anti-inflammatory antibiotics, the tetracycline group, they are anti-inflammatory and they have anti-neutrophilic action. Clindamycin is another one. And the third one, which I read up only yesterday, I've never used it, but it's come up in a big way, is oral fusidic acid. Another one which has anti-neutrophilic agent and has anti-inflammatory action alongside being an antibiotic. Clofazimine, thalidomide are hit or miss. Thalidomide has a weak TNF alpha effect of his own. So these are sometimes employed once when we are waiting for the diagnosis to happen. And we have a severe systemic involvement and it's a crisis situation. The two drugs we go to which are fast acting are systemic steroids, sometimes as pulse, uh, which is the methylprednisolone pulse, generally given by a physician, or we give them a daily steroid or daily cyclosporin, and sometimes in combination. If you look at the guidelines for pyoderma gangrenosum, the guidelines say start 1 mg per kg of steroids plus 3 to 5 mg kg of cyclosporin together. So these are the drugs we use to as a crisis, but both these have a problem. We can't be giving them for long periods, so we end up tapering them and start maintenance drug if the patient continues to develop neutrophilic dermatosis, and methotrexate and MMF are generally the chosen options. Azathioprine has not been shown to have a lot good effect in patients with neutrophilic dermatosis, and if the patient can afford and their situation demands it, a biologic is employed. So these are the two articles which I have not included uh, in my talk, but I want you to go back and read through them. They give you something which is more than what your textbook will give you. The first one is an update, recent update, which tells you all the classification criteria and gives you a list of drugs and the evidence of their uh, efficacy in neutrophilic dermatosis. And the other one is the one which says, are all neutrophilic dermatoses autoinflammatory disorders or not? So I want you to go through these to have a full, uh, you know, idea of what neutrophilic dermatoses are. Uh, these are places where I'm working at the moment, and if you have any questions, I'm happy to take them now, or you can email to me whenever you have them. Thank you so much.
Really, it is a wonderful talk. It's very crisp and very clear. That is, I love that presentation. And right from the beginning, from your student days, you are to the point always. So you are maintaining that. Congratulations to Ankit. So anyway,
Thank you, sir.
he has given a very good outlook of neutrophilic dermatosis. It is, and now your duty is to expand on this. He has given some suggestions. You have to go back and read your textbook, plus the journal article where you have good review and case reports, case series, all those things you have to read. No, without reading or supplementing the talk with your work, it's not going to help you. So you keep the presentation in your mind and then supplement your effort with more and more knowledge to neutrophilic dermatosis. And don't be under the impression that neutrophilic dermatosis is a very rare disease. It is common, and if you are working in a secondary care hospital or tertiary care hospital, you will come across a lot of neutrophilic dermatosis. So it is of practical importance, not only to pass the examination, but also in your rest of your life. So read neutrophilic dermatosis, have a good idea about that. And Dr. Ankan has given a lot of clues how to go about doing a biopsy, doing a blood examination, all those things, and you can incorporate into your practice. So, so my advice is that as students, you read neutrophilic dermatosis once again in the with the Dr. Ankan's presentation. So, good. So I congratulate once again Dr. Ankan, and I am very, very much grateful to you for taking your time out of your schedule to come and to talk to the postgraduates of India. And of course, I will bother you again in some other time. Okay, thank you. Thank you,
Thank you,
Dr.
sir. My pleasure, sir.
And this recorded version is available in our East West Pharma YouTube channel, and you can contact our East West Pharma people. They will share the link. Shortly, the edited video will be uploaded in the channel also. So once again, we are thank you, and we will meet in the next program. Thank you, doctors, both speakers, as well as our host director, Dr. Ketan sir and Angan Gupta. Thank you, sir.